good.
So it's 5 o'clock. Do I have your permission to say we are open for the webinar?
Yeah.
Yes, go ahead.
Thank you, Jafar sir. With your permission, sir, Ved Prakash sir, I'll open the panel.
Yeah.
Good evening and thank you everyone for joining this webinar. I am Dr. Amit Borse from MCure Pharmaceuticals Limited. MCure is a pioneer in the field of IVF and gynecology and will always be there to support all the academic activities. We are very thankful to Dr. Ved Prakash sir to give us an opportunity to be an academic for this great event. This event, a UA team initiative, Innovation in Laboratory Aspects of IVF and Andrology series, which is the second in number, we have started today, and today's webinar, Revisiting Fertility Strategies in ART, will be our focus. Importantly, I'd also like to introduce Dr. Ved Prakash sir. Dr. Ved Prakash sir is the lab director for Southern Fertility and IVF, Delhi and NCR. He's a master's in biotechnology, trained in IVF and ICSI from Andrology and IVF Lab, KK Women's and Children's Hospital, Singapore. He has done advanced IVF and ICSI and embryology biopsy training at AZBU, Brussels, Belgium. He is a vice president for Academy of Clinical Embryologists, India. He is also the founder for Human Embryology Research Academy. And thank you, sir. And the session is all to you. Please take it forward, sir. Dr. Ved Prakash, sir?
Yeah. Sanket, you have to share the screen. Not this one, that video.
Yes, sir.
So thank you, Dr. Amit, for nice introduction. On behalf of ihera and MCure, I welcome all of you. This is our fourth webinar, and this is our fourth webinar on revising fertilization strategy in ART. I am audible?
Yes, sir, very well.
Yeah. So today we are going to focus on fertilization. First topic will be on basic fertilization events, and second topic will be on how to maximize the fertilization in the ART. So we have two moderators here, Dr. Sanket Dhumal. And Sanket Dhumal Satya is Executive Member of Academy of Clinical Embryologists, Senior Clinical Embryologist, Chama IVF Fertility and Reproductive Medicine Center, Department of Gynae, Justice K.S. Hegde Charitable Hospital, and he is done PhD in Reproductive Biology, University of Bangalore, and he is the team leader of our ihera Academy. And second moderator is Akash Agarwal. He is MBBS, SRA certified clinical embryologist, scientific director, Hegde Fertility Hyderabad, anomaly of Osmania Medical College, practicing male fertility and embryology since 2011, and he is a topper SRA clinical embryology, Vienna 2019. He is actively involved in academics and has co-authored a book chapter. He is an active member of National and International Fertility Organization, ASHRAE, ISAR, IFS, ACE, and he has participated in multiple national conferences as faculty and conducted multiple workshops in andrology and embryology, including vitrification and IUI, and his keen interest in male infertility treatment with surgical retrieval sperms. So over to Dr. Sanket and Dr. Akash Agarwal to moderate the session.
Thank you so much, Ved sir, for your kind introduction. Am I audible?
Yeah, please.
Yeah. So a very good evening to all, and first of all, happy Ganesh Chaturthi to all, and it takes me immense pleasure to introduce today's first speaker, Dr. David McCullough, and currently he is working as an assistant lab director at NYU Langone Medical Center, and he's a multifaceted person with he's a prolific academician and a very experienced teacher and a lab director. He has the experience of 3 decades of directing at laboratories, and he has published hundreds of publications in internationally reputed journals, and suffice to say that his articles has more than 1.5K citations, and I can continue like this. For which the entire session won't be enough, and without taking much of your time, I'd invite Dr. David to take over the stage.
Well, thank you very much for that kind introduction. It's a pleasure to have been invited to speak here, and I thank Ved Prakash for inviting me. It's really exciting to be involved in international stuff like this. So let's see if I can get started here. I'll share my screen so that hopefully you may see it. All right, I think we're there. All right, so I'm going to talk about basic science and in vitro fertilization. As you can see, I'm at NYU in New York. I also work with a clinic in the Republic of Georgia. And that clinic actually is moving, so coming soon we'll have a facility near New Delhi. So we can talk a lot more then. Let's see if I can get this to work. There we go. So I have a number of disclosures. The assistant lab director you know about. I'm also lab director at 2 andrology labs. And here's the ReproArt facility in Georgia, coming to India soon. I'm also the principal scientist at my own consulting company. I've been a member of the advisory board at Granada Bio for a couple of years now. We're bringing various products for IVF patients to the United States, basically from Europe. I've also received honoraria from Ferring Pharmaceuticals, and of late this year I'm the chair of the SART registry committee. The SART is the Society for Assisted Reproductive Technologies, which is an affiliate society under the American Society for Reproductive Medicine, ASRM. And we actually have a national registry for IVF results. And I happen to be the chair of that committee, so I am tainted by being involved with that. So I'm going to talk about basic science. To me, basic science is involved with assisted reproductive technologies, which has the goal of creating live birth of a healthy baby. And we want to achieve the best possible efficiency, meaning the fewest attempts to achieve the highest incidence of live birth. And we ought to have the healthiest possible outcomes, which these days we focus very much on having singleton live births. We've been transferring only single embryos for quite some time in New York. We'd like to believe that the knowledge of the basic science of fertilization can help us to maintain or improve the quality of our gamete treatment during IVF. So I think it's important to understand some of this basic science. So that's why I'm going to talk about some today. Today, I'll talk about 2 topics. The first one is sperm capacitation. And let me set this up. Let's see, never mind. All right, there we go. Start my timer. Okay. And the second is sperm-egg fusion. These are pretty important events in vitro fertilization. And I'm going to talk to you about them because they're really quite old, like me. Sperm capacitation has been around for quite some time. We learned about it actually before I was born. Sperm-egg fusion is something I focused on quite a bit in my earlier research years, and I think it has had a lot of implications that are interesting that help us to understand why some things have been working of late. So, topic 1, sperm capacitation. Hopefully everybody's aware of this, perhaps you're not. Sperm undergo a change that results in the sperm having the capacity to fertilize mammalian oocytes. Sperm out of the testicle don't have that, not immediately. They gain this capacity actually only once they've been in the female reproductive tract. And it was a very important finding because early on, for many years, people had been trying to perform IVF, but were having a hard time getting fertilization. Sperm were mixed with mammalian oocytes, and fertilization just wasn't happening. So in this report from MC Chang, published in October of 1951, that's before most of you were born. It's before I was born. And Chang found that by placing sperm in the rabbit's fallopian tubes, basically, that at various times prior to and following ovulation of the rabbit, they were able to see that there was a dependence on how long sperm resided in the oviduct. I'll go back. I find this particularly interesting because this is the entire paper. This is the whole paper published in Nature in 1951. It was 2 columns. I broke it into 4, and it has one table that I will summarize here. This is that table, and it shows the time that they placed sperm into the oviduct prior to, which are positive numbers, or after the time of ovulation, because they induced ovulation with an injection of basically chorionic gonadotropin. But they introduced the sperm 8 hours, 6 hours, 4 hours, 2 hours before ovulation, and an hour after, and a 2 hours after. And here are the actual numbers, which I will show in a graph. I think it's pretty remarkable that if we look at the time prior to ovulation, and we look at what percentage of the oocytes were fertilized, if sperm were placed in the oviduct 8 or 6 hours prior to ovulation, good fertilization occurred, 50, 75%. 4 hours before, a few of the eggs got fertilized, but if sperm were placed as late as 2 hours prior to ovulation, there was no fertilization. And the point was, this summary in the discussion says the present finding indicates a possible physiological change of the spermatozoa in the female tract. This may also explain the lack of success of attempts to fertilize mammalian ova in vitro with ejaculated or epididymal sperm. The point was, sperm needed to reside in the female reproductive tract for several hours in order to acquire the ability to fertilize the oocytes. Now, here's a picture of me. This may be easier to recognize as me, Dade. I don't have the facial hair here. I was 3 or 4 years old here, and actually that means it was about 4 or 5 years after this report came out. But I wanted to give you an idea of how long ago this was. And this was me in my backyard many, many, many years ago. Well, we moved on, and the acknowledgement that sperm had to reside in the reproductive tract was figured out back in 1951, and people were able to mimic that with treating sperm in a medium that contained a lot of bovine serum albumin, BSA. And so several years later, when I looked more like this, I visited Don Wolf's lab in Pennsylvania, and Kathy Go was working on her dissertation, and she was examining albumin's action on capacitation. What she found was that she could treat the sperm with albumin, and they would, of course, capacitate. This is very important because this meant that we could get capacitation of sperm in vitro. But what she did was actually dialyze the albumin and remove all of the lipids from it. And the bovine serum albumin still worked very well. But if she then loaded the albumin with other lipids, and in particular with cholesterol, she found that that the sperm were no longer, and she exposed the sperm to this bovine serum albumin that was loaded with cholesterol. The sperm were no longer capable of fertilizing eggs. So the conclusion was that albumin was acting as a sterol acceptor, and it was actually drawing sterols from the sperm membranes, and that was a necessary step in achieving the ability of those sperm to fertilize oocytes. So the conclusion was that that it was important to have albumin present because it acted as a means of removing sterols from the sperm membranes. This was how capacitation was occurring. I'm now going to move on to topic 2. I'll summarize everything in the end, but topic 2 is sperm-egg fusion. Now, sperm-egg fusion is the process whereby the contents of the sperm and the contents of the oocyte are joined within one continuous volume of sperm oocyte cytoplasm, the joined cytoplasm. This permits the entry of the sperm's nucleus, very important that we get that in there, the sperm's mitochondria, the sperm centriole or centrosome, and the axoneme, the microtubular structure of the sperm tail. All these things go completely into the egg, the oocyte, during fertilization. So it's a very important event, but I wanted to learn something about when sperm-egg fuse occurred because I wanted to know how the sperm activates development of the egg. So in 1985, I began to question, how does the sperm activate development in the egg? Is it via an extracellular receptor-mediated mechanism, as was quite in vogue at the time? We were all very intent on looking at second messengers and membrane receptors that were binding various ligands. Everyone thought that that was how the sperm was activating the egg. But an alternate possibility was that the sperm was activating the egg by transferring a sperm cytoplasmic factor into the cytoplasm of the egg that would occur after there was the ability of things to diffuse from the sperm into the egg after sperm-egg fusion. Well, let's stick back one more step and ask a question about oocyte activation. The important step of oocyte activation, at least to a physiologist like me, were an explosive calcium release. Calcium is released in the cytoplasm of the egg, and it actually happens explosively. It's a positive feedback cycle whereby release of calcium from internal stores causes an increase in cytoplasmic calcium concentration, which leads to an increase of phospholipase C activity, which then catalyzes the breakdown of phosphatidylinositol 4,5-bisphosphate, that's PIP2. It's broken down into inositol trisphosphate, IP3, and diacylglycerol, DAG. The inositol trisphosphate then acts on the internal stores it increases the concentration in the egg, but that then leads to the release of calcium stores from these internal stores. So each step along the way causes the next step, and if you do anything to increase any of these factors anywhere in the egg, it will cause this explosion. If you add calcium into the cytoplasm, it causes increase of phospholipase C activity. It causes everything else, and it causes an increase of cytoplasm, of calcium in the cytoplasm. If you inject inositol trisphosphate into the egg, it will cause this positive feedback loop to happen. So the problem was, we could inject a lot of things into the egg that would cause this positive feedback cycle, but we didn't know what it was the sperm was doing. Lots of people thought it was calcium. There was the calcium bomb hypothesis, postulated by Lionel Jaffe. He said the sperm is putting a bomb of calcium into the egg, and that's causing this positive feedback cycle to happen. So it results in a calcium increase throughout the egg and activates the egg. We weren't so sure that was true. Other people, Michael Whitaker at University College in London, injected IP3 into the egg. It activated the egg. It causes the same cycle. But was that what the sperm was doing? It wasn't clear. So we wanted to know what are the mechanisms involved. And so, again, we wondered whether the sperm was activating the egg by a sperm receptor binding phenomenon where there's some kind of chemistry going on inside the egg after binding of the sperm to this receptor, or whether the sperm fuses with the egg, and then this little channel between the sperm and the egg opens up and allows diffusion of molecules between the sperm and the egg, and whether that might be the case. So we wanted to find out when the sperm actually fuses with the egg. When does it occur? And the work that I did in Miami with my advisor, Ted Chambers, led to this paper, which was published in 1992, although the work was done substantially before that, that we were able to look at the fusion of the sperm with the egg by using electrophysiological methods. We had looked at a lot of different electrophysiological things in the egg causing the fertilization potential. We looked at voltage clamped eggs, so we were actually looking at the currents, the ionic currents flowing through the plasma membrane of the egg. And we could monitor that with a microelectrode put inside the egg. But for this particular experiment, we pushed a large patch clamp pipette up against the surface of the egg. And what was unique about this was that we actually introduced the sperm only inside the pipette. Therefore, the fertilization events had to occur with this small patch of membrane that we were investigating with the patch pipette. This is an equivalent circuit down below, but the point is that as the sperm fuses with the egg, that increases the surface area of membrane. And the surface area of the membrane is measured as capacitance. It is directly proportional. The capacitance of the membrane is directly proportional to the surface area of the membrane that we're investigating. So we looked for fusion of the sperm with the egg as an increase of capacitance for this little patch of membrane that we were looking at where the sperm's fusing. This shows the traces that we had. This is the current measured through the entire plasma membrane of the egg. This is the current measured only through that small patch where the sperm was fusing. And this is the capacitance of that small patch. And what we saw was the typical thing that we always saw. The initial event was a small inward current that occurred shortly after the sperm would attach to the surface of the egg. This goes on for a while, and then several seconds later, in this case around 20 seconds later, the activation occurs where there's a wave of calcium that goes through the whole egg and opens up a bunch of ion channels that lead to further inward current. So we saw an initial inward step current, and then we didn't have activation occurring until quite a bit later. This is when calcium rises. In the small patch, we saw this same step inward current, and it's very similar up to around this point in time, around 20 seconds. And when we looked at the capacitance of that small patch of membrane, it stepped up at the same time as these currents turned on. So the sperm-egg fusion is interpreted as this step up in capacitance that occurs at the same time as we see these currents. The point is, sperm-egg fusion happens before activation, several seconds, well spaced in time. If we look at the currents through the patch in these dots, okay, and we superimpose them on the currents measured from the whole egg, we see that for the first 17 seconds or so, these currents are identical. Now that means that all of the current flowing into the whole egg is flowing through that small patch. We believe that the currents are actually flowing through the sperm membrane after it is fused to the egg, and actually flows through the sperm membrane and through the neck where the sperm and the egg are joined because of fusion. About 9 years later, Sherwin Lee and his colleagues looked at the same thing in mouse eggs. They saw a step up in capacitance corresponding with sperm-egg fusion, and this preceded the activation events in this box by about a minute, so 60 seconds. So they concluded that sperm-egg fusion is indicated by a 2 picofarad step increase in the mouse egg capacitance, just as we had found in the sea urchin about 9 years before. and that after the fusion event itself, the earliest consequence of egg activation was an accelerating increase in calcium concentration that began around 1 minute after sperm fusion. So, when does fusion occur relative to the time of activation? Fusion occurs prior to the activation events. The activation events of calcium release, cortical granule exocytosis, which leads to another capacitance increase throughout the egg in this case, and prior to the resumption of development. Since fusion precedes activation, then cytoplasmic continuity and the ability of cytoplasmic molecules to diffuse freely between the gametes could be the mechanism for signal transmission during activation. This was a pretty big deal when we learned this, because it made it possible to believe the idea that it was fusion that was leading to egg activation, not a receptor-mediated phenomenon. It didn't prove it, but it definitely made it a possibility. Well, since then, there have been some other findings that I think support this idea that it is cytoplasmic activation due to diffusion of molecules from the sperm to the egg. The first piece of evidence is intracytoplasmic sperm injection. I bet many of you have performed this yourselves. And in 1992, Palermo and his colleagues from Belgium published this technique where a sperm is directly injected into the cytoplasm of the egg, and it never has to come in contact with the surface of the egg, so that it certainly bypasses any receptor binding of the sperm to the egg, and yet the egg is activated. That suggests that there is not a receptor required. And it further is supported by the idea that injection of phospholipase C zeta, something that's been pushed forward, an idea that has been out there from Swan and his colleagues from 2000 and on. He has many publications of this, actually started even earlier, but he started getting at the phospholipase C idea in around 2000. And so injection of phospholipase C is capable of causing that explosive release of calcium. And that's something that he isolated from sperm. So it certainly is a major contender for something that is causing the activation to occur. So in summary, sperm capacitation. Well, sperm gain the capacity to fertilize oocytes while in the female reproductive tract. In vitro, we use high concentrations of albumin for sperm prep and for fertilization. It's important that we realize that this albumin is performing a function to make it so that the sperm can fertilize the egg. If we take the albumin away, we may not get any fertilization. We don't want to go back to the problems that were found prior to 1951, just because we aren't aware of them. So it's important that we're aware of the importance of albumin for capacitation. For sperm-egg membrane fusion, we found that it's a very early event that precedes the activation events in eggs. It allowed us to realize that injecting a sperm into the egg, bypassing the surface contact of the sperm and the egg, can indeed activate the egg. We didn't have to worry about activating some receptor on the surface of the egg. It can be done by getting the sperm into the egg, and actually at the low calcium concentrations inside cytoplasm, that tends to permeabilize plasma membranes of the sperm so that stuff inside the sperm can leak into the egg. And I suspect that's how the activation occurs. It also allowed us to focus on sperm cytoplasmic molecules like phospholipase C zeta rather than on sperm receptors. Now, that's basically the summary, but I have one final question for all of you. Let me set it up. Sperm-egg fusion is crucial in allowing the sperm to activate oocyte development. We can see that from some of the stuff I presented. However, egg factors bind to receptors on the surface of the sperm membrane and initiate this cascade of events that leads to generation of phospholipase C zeta inside the sperm. This happens when the sperm gets close to the egg. So, is oocyte activation mediated by fusion or by receptor binding? And I'll leave that to you. I thank you for your attention, and I will stop sharing my screen. Thank you very much.
Thank you very much, Dr. David, for your excellent presentation. So you took us through the journey of sperm and egg interaction along with your journey as well. So that was fantastic. And are we taking questions now, or are we proceeding with the next lecture? Hello.
Just a minute. Sanket, you can take 2-3 questions.
Yeah. Thank you, sir.
Okay.
So, David, there's a question from one of our participants that could you please comment on the time taken for capacitation with respect to human sperms?
I think that we can get capacitation to occur with human sperm since we expose them to albumin. Happens pretty rapidly. I'd say it's certainly less than an hour. Usually we perform our swim up or our final wash after a Percol type wash, a density sedimentation preparation technique. And then we actually have high albumin around during fertilization as well in the fertilization medium. So the time it takes probably is less than an hour, but it may be a little faster than what happens in the rabbit. Also, by the way, the experiment bypassed the uterus, which is the place that most of us use to capacitate sperm when we were doing it inside the female reproductive tract. There's the volume of the uterus is quite a bit larger, so we're able to get a lot more sperm in there and get them capacitated in there. So perhaps the oviduct isn't quite as affected, but it seemed to be pretty clear that it made a difference in Chang's work. Thanks.
Yeah, there's a follow-up question with respect to this. So what are the factors affecting it not to capacitate in vitro?
The factors that are affecting capacitation in vitro?
Yeah.
Well, one thing is we like to have a lot of bicarbonate around because that seems to play a role as well. But it seems to be the presence of albumin as a sterol acceptor, and high bicarbonate also seems to facilitate things. So we use medium with high bicarbonate and albumin. Those are the main things that we know are playing a role.
Okay. And there's another question. Could you please explain us the role of the ZP1, ZP2, and other zeta factors or receptors which are present on oocyte, which are involved in the interaction of sperm and egg interaction, during fertilization process?
Well, the idea is that the activation of the sperm, which is separate from capacitation, it happens probably as the sperm traverses the zona pellucida. It's probably something happening with the zona glycoproteins. But it activates the sperm so that the cascade of events that results in the evolution of phospholipase C in the sperm occurs. Then once the sperm fuses with the egg, the thought is that this phospholipase C zeta can diffuse into the egg. It then acts as phospholipase C in the positive feedback cycle that I showed you, and results in the breakdown of PIP2 to IP3 and diacylglycerol. The IP3 acts on the internal stores of the egg to release calcium. Calcium builds up, and then it too can further activate the phospholipase C zeta, which is shown to be calcium dependent, and further activates this positive feedback cycle, resulting in dumping of calcium stores into the cytoplasm of the egg. And then that actually can propagate throughout the egg as well.
So you mean to say that it's a cascade of events
Yes.
where the interaction occurs first, followed by the activation or release of the PLC zeta factor into the oocyte, which makes the cortical granules release the calcium.
It makes it's sort of smooth endoplasmic reticulum type source, we
Yes.
believe,
Yeah.
for the
Yes,
calcium.
sir. Yes, sir.
And it's the calcium is released from there, then acts on other phospholipase C molecules that may be around, and those then activate the breakdown of PIP2 in membranes throughout the egg, which then evolves IP3 that then leads to more calcium release, and it just continues positive feedback and propagates throughout the egg, so that the whole egg ends up dumping its calcium, which then gets resorbed. But something about the release of the calcium activates many, many different events that are that follow.
Are there any studies that are related to the quantification of PLC zeta factor in sperm, individual sperms?
I didn't understand. Can you say it again?
Are there any studies that support the quantification of PLC zeta with respect to single sperm?
Certainly, I'm pretty sure Carl Swan's group has looked at that. They're isolating the PLC zeta from sperm. I think they tend to use boar sperm that they can get a lot of, but they have shown that it is found in all kinds of mammalian sperm. And I think that the boar sperm PLC zeta is quite capable of activating mouse eggs, showing that there's a cross-species capability there, and doesn't seem to be species specific.
Okay.
Seems to be pretty universal throughout the mammals, I believe.
Great. Thank you, Dr. David.
Just a last question from Dr. Jafar Ali. Albumin, one question, albumin does appear to be necessary for fertilization in vitro. Any comments?
Say it again.
Albumin does appear to be necessary for fertilization in vitro. Any comments?
Oh, I think its main role that we know about for sure is that it's important for capacitation of the sperm. Now, it could have other roles as well. I'm not aware of them, to be honest. But albumin has been a common substituent of culture media for decades, providing all kinds of factors. It's bovine serum albumin is not really a very clean substance. It's got lots of stuff associated with it. So there may be all sorts of growth factors in there, and only when you clean it up do you find out what the real role of the protein is and what the role of the stuff that's adhering to it is. So it seems pretty clear from Kathy Go and Don Wolf's work that for sperm, it's acting as a sterol receptor, a sterol acceptor that then draws the lipids, the cholesterol in protect. I mean,
the last question is, sorry. Please continue.
It's an acceptor of sterols that it seems to be able to draw out from the sperm membranes, and that seems to be a critical event in capacitation. Go ahead.
Yeah. Last question: is there any test or technique available to find capacitation of sperm?
Yeah, the only test is the one similar to what Kathy Go did. You find out whether the sperm are capable of fertilizing the eggs. It's always been a mysterious phenomenon. It's really a funny thing where you're determining whether the sperm have the capacity to fertilize eggs. So the only way you can test to see if they have the capacity to fertilize eggs is to see if they can fertilize eggs. It's goes back to those bioassay days. It's not something you can put on the PCR machine yet.
Okay. Is there any other questions?
I think that's all, sir. We have covered all the questions. Which are question for Dr. David.
Thank you.
Thank you very much.
Thank you so much.
Thank you so much, sir.
Thank you. Please continue, Sanket.
Yes. So, thank you so much, Dr. David, for answering all the questions which are raised by our participants, and it was very interactive session as well. And I think Akash can take over.
Thank you, Sanket. Good evening, everyone. I would like to say first, thank you to Ved sir for the initial very kind introduction of mine. And what a wonderful session we had with Dr. David McCullough just now. From the journey of the sperm to his own journey, like it had been said. So it's a peek into what people had undergone initially, so that we have something similar, very easy for us to just say it's a capacitated and acrosomally reacted sperm. So taking the session forward, I would like to introduce our next speaker, Dr. Parshuram Gopinath. He actually needs no introduction, I would say. Specifically, he doesn't need any introduction. He is on the managing committee member of ISAR 2021. He is a member of ISAR Accreditation Committee 2020. He is executive committee member of ACE. So he's quite a pretty well-known figure in all the infertility circles. Dr. Parshuram is presently working as a medical director at CMAR Cochin at Kochi in Kerala, God's own country, where he happens also to be the scientific director. He is working as a visiting consultant at Paul's Hospital, Kochi, Kerala, and he also happens to be a teaching faculty at Edapal Hospital, which is a national board accredited training center for your DNB, Obs and Gynae, reproductive medicine and high risk pregnancy and perinatology. He is not a new for awards as well. His latest awards being Manish Bankar Young Achiever Award as a clinicians in 2020 and Champions of ISAR Award for 2019 and 20. So he's a regular speaker at all national and international conferences. He has many articles and studies in reputed journals. So without taking much of your time, I would like to hand over the session to Dr. Gopinath, who has over 3,000 ICSI cycles to his credit. Over to you, Dr. Gopinath.
Thank you, Akash, for the kind introduction. And so I'll just start with sharing my screen.
Yes, sir, you can start sharing your screen.
Is it clear at this point of time?
Yes, sir.
Okay, all right. So very good evening to one and all. It's indeed a pleasure to be back on the regular online webinar platforms. And today, I think probably all thanks to Dr. Ved for this opportunity. It was a little difficult topic for me, which I had to kind of struggle and find out about the different possibilities of how we can improve our fertilization rates. And so thanks to the whole team, Dr. Ved Prakash, Sanket, Rahul, and all those, the whole group of ihera for this opportunity. And when I always try to begin with what I need to speak on, I always try to kind of compare it with things that we always do on a daily basis. I think being the quarantine phase, I think almost everybody here have at least attempted to cook something on their own. And I think probably they would have had that realization that whatever they do, ultimately your end product is primarily because of its ingredients and also the cook that makes it. So there are several factors. Even if the same person gets the same ingredients, probably not necessary that we end up having a good product unless the cook is good enough. So it is when you compare it with that kind of a synergy, when we talk about fertilization in the same lines. See, even with so much of technological advances, so much of advances, sophistications that has come in, we still are only able to get a fertilization rate of around 70 to 80%, which is a fairly good one. But the biggest challenge as doctors that we face here is when we have a fertilization failure. It is a big challenge to talk to a patient as to why fertilization failure has happened, talking to them, because there is a lot of questions that need to be answered to. And the biggest challenge is to when we are having situations where when we have a total fertilization failure. As you all know, it does have an incidence of around 5 to 10% in the IVF cycles and 1 to 3% in ICSI cycles. And to be very general, what we have always understood is that most of the time, when there is a fertilization failure in IVF, it is probably mostly because of the sperm, not necessarily always. Whereas when there's a fertilization failure, as far as this in an ICSI cycle is concerned, mostly we assume that the problem is with the oocyte. This is a very general statement. I wouldn't categorically say that this is right, but in general, that's what I'm talking about. So before we always talk about the ingredients, that is the sperm or the egg, we always need to know also that the cook is right, or probably the person who makes it is also needs to be correct. Because ultimately having the ingredients and not able to prepare it well is as good as not having a good fertilization. So similarly, if your ICSI technique has got issues, especially people who are starting off with their cycles, you could have had situations where we realize that how the ulama needs to be bypassed. If the sperms get stuck onto your needle, when you accidentally excessively aspirate the ooplasm, or injecting, you're not completely immobilize the sperm, the timing of the ICSI, all these can contribute to fertilization failure. So basically, when we actually have fertilization failures, you need to actually relook at the procedure, at the technique that we are doing these procedures. Another very important factor is also the kitchen. So when we're talking about the lab, it's very important as far as the culture media is concerned, the gas is concerned. All these can contribute to a fertilization. So if there are some issues which are associated, which can be detrimental to the fertilization, that needs to be corrected, or all things needs to be checked before these procedures can be done. So keeping these two other scenarios and out of our talk, let's focus on the two main ingredients, that is the sperm related and the oocyte related. So when we're talking about the sperm related scenarios that are causing decreased fertilization rate, I think one of the most important is the structural deformities that are seen in the sperms. So in general, I would like to kind of focus on three main things. One is when we have semen samples or semen having similar, almost 100% of the semen sample having similar structural defects, like we have it in primary ciliary dyskinesia, Cartesian syndrome, wherein all the sperms are affected, can cause decreased fertilization or no fertilization in this group of patients. Similarly, in situations where we have abnormal morphology of the head with large vacuolations, which are more than 20% of the cross-section size of the head, can probably decrease your fertilization rate. And we can also have scenarios where we have an issues with the echrosome, either the partial absence or complete absence of echrosome, which can probably have an not be able to activate the oocyte, or and there is no echrosome reaction that is happening, which is not able to activate these oocytes, can also cause fertilization failure. So if you look at it in that scenario, what are your suggestions or probably the treatment strategies that we are able to do in these kind of scenarios? If you look at it, one, definitely when you have a situation with primary ciliary dyskinesia or Cartesian syndrome, that is 100% immotile sperm. Most of the time, ICSI does our job. But it is very important when you're actually selecting for a sperm for ICSI that we should make sure that it is live before we select it, because it is very important to differentiate between a live immotile sperm and a dead sperm. Another, again, important aspect where we're talking about vacuoles in sperm is, I would say, a good sperm selection, not necessarily always an IMSI, but a good sperm selection process might do our job as far as selecting the better sperm is concerned. With regards to globospermia, what we should always have in mind is not necessarily all patients with globospermia will going to have 100% fertilization failure. We have situations where we can actually do some kind of, even the routine ICSI will end up having fertilized oocytes. But if you're having a history of fertilization failure in this group of patients, we can add on some oocyte activation factors in these group of patients, which will benefit our fertilization. Then comes to the aspect of a motility. Any kind of sperm motility affected can lead to a decreased fertilization rate. Even in patients with ICSI, especially like I say, when you're having 100% immotile sperms, there are different ways in which we are able to select between a viable and a non-viable immotile sperm. As you all know, the hypoosmotic swelling test, one of the most commonest used test for selecting the sperm. Another tests that are available are the you actually have the provision to add motility stimulation agents like pentoxifylline. You have laser shots which can be done, which will make the curling of the tail, which can help in the live sperms. We even have techniques such as sperm tail flexibility, wherein we'll be able to know the flexibility of the tail and identify the sperms which are live. And with all these scenarios in patients with sperm motility defect, we are able to bypass, or any kind of fertilization failure can be bypassed with the help of ICSI by selecting a live sperm. Sperm DNA fragmentation is again a very thought about or very kind of studied entity as far as any kind of IVF failures are concerned. But we do talk about poor fertilization, implantation failures, and higher miscarriage rate. But what we should always understand, in majority of the patients with sperm DNA fragmentation, the embryonic genome activation happens by around 4 to 8 cell stage. It's only at that point of time the paternal genome comes into effect. So rather than having fertilization failure, most of the time in these group of patients, we end up having arrest of the later stage of growth of the embryos, or implantation failure, or recurrent pregnancy loss. But if you want to kind of complete the topic, probably when we look at in patients with high DNA fragmentation, there's a very interesting chart that has been suggested by Sandro Esteves et al., wherein they actually tried different scenarios. One is always reduce the possible reasons of oxidative stress in these group of patients, like avoiding smoking, correcting your obesity, using oral antioxidant therapy before we start the treatment. In situations where we are able to find an exact reason, which is probably the reason for an increased oxidative stress, like the presence of varicocele, genital tract infections, presence of diabetes, any kind of metabolic syndrome, it is important that we correct that before we go ahead with an IVF process. And when we are selecting sperm for ICSI, I think one of the most commonest way, or probably the most successful way they talk about selecting a sperm for ICSI in patients with repeated ICSI failures with high DNA fragmentation is to use a TISA sperms. Other ways of selecting sperms with high DNA fragmentation can be done by microfluidics, MAX, ICSI, IMSI. But what is to be always understood in these scenarios is that even though all these possible techniques do tell us that there is a possibility of selecting better sperms, but are we actually avoiding the sperms with high DNA fragmentation? We do not know. It is not proven effective. But if you're looking at in patients with repeated IVF failures, probably any of these techniques can be added to your strata of test. Now, once your sperm is complete, now we're going to talk about the oocyte related factors that can cause fertilization failure. But if you look at oocytes, I think there is something that we always need to keep in mind, is that the oocyte related factors, probably we have limitations in treating, especially in patients with poor oocyte quality, where we end up getting a lot of immature oocytes, in poor responders where there are very less number of oocytes. In all these scenarios, unlike sperms, when we are talking about selecting sperms from millions of sperms, we have only a reasonably good number of, very few number of oocytes, and we need to do the treatment with that kind of oocytes. Even if you look at morphology of the oocytes, like I said, if we have bad morphology oocytes, definitely we know that it is bad, we end up doing it. We know that there's a possibility of fertilization failure in this group of patients, but there is little much that we can do about in these group of patients. Probably the only way that we can do in these group of patients is try and use different kinds of stimulation protocols in a following cycle. One interesting fact that I came across in this group of patients is that in patients, especially in poor responders, when you're giving higher gonadotropin dose, there seems to be an impact or decrease in quality of oocytes, because you end up stimulating those poor quality oocytes and hence producing more aneuploid embryos. Contrary to the belief that it's not the higher dose of gonadotropin that matter, it is a higher dose of gonadotropin that actually is going to decrease your egg quality, and not higher responders. If you're looking at higher responders, not necessarily has a decreased quality of oocytes, but probably because of high levels of estradiols in this group of patients can cause some kind of an endometrial effect that can decrease your implantation, and not necessarily the quality of the oocytes is not affected in high responders. And just like we are talking about different kinds of scenarios where we can add different kinds of adjuvants, any kind of stimulation protocol, if you find that the oocyte quality is less, the next cycle, or probably in patients with a poor reserve, we end up adding different kinds of adjuvants. Like we're talking about using LH supplementation, use of growth hormone. Even we talk about the use of different kinds of triggers, because generally what general trigger that happens for an LH for an IVF cycle is always an HCG trigger. But in situations where there is hyperstimulation, or in situations where there is when there is an antagonist cycle, there is an importance of use of gonadotropin agonist trigger. What they say is that in a natural IVF cycle, it is not only an LH surge that happens, it's also an FSH surge. So the FSH surge is also an important factor in helping us achieving more mature, good quality oocytes. So adding FSH in the form of agonist trigger or a dual trigger or an FSH co-trigger along with your HCG do tend to give us more good quality oocytes. But again, none of this has been proven. We are having studies with all these things that are being published. Now coming to the major part of the talk, or probably the most commonest way in which we address our fertilization failures. I think David did talk about the whole cycle, or the whole way in which an oocyte is activated. Once the sperm fuses the oocyte, there is this chain of reaction. But to have a basic understanding, I think one thing that you should always understand is that because of whatever reaction that happens, there is always this calcium oscillation or high calcium levels that are made in the oocyte that is going to stimulate the oocyte, or that is going to complete the process of the maturation of that metaphase 2 of that particular oocyte. So there are several ways in which we can artificially activate these oocytes. There is an electrical activation that is available. You have mechanical oocyte activation that has been proposed. But the most commonest way in which we are actually using oocyte activation is by the chemical activation, wherein we use calcium ionophores. As far as chemical activation is concerned, what they try to do here is put in separate pores in which we are able to, so that there is flow of calcium from the extracellular area into the intracellular area, so we can have higher levels of calcium inside the cell, and that further helps in completion of the oocyte activation. Whereas mechanical oocyte activation is a particular way in which you use modified ICSI techniques. One way that they talk about doing an ICSI is by doing a very vigorous cytoplasmic aspiration. What they try to do in that particular scenario is that when you're doing a vigorous cytoplasmic aspiration and then injecting the sperm along with that the vigorous aspiration, there is an accumulation of the mitochondrial bodies and a release of calcium, which will at that point of time helps in stimulating or activating the oocyte. Another way that they talk about oocyte activation mechanically is by aspirating the peripheral cytoplasm, which is supposed to contain higher mitochondrial levels, and aspirating that, and along with the central and dropping those peripheral cytoplasm along with the sperm into the center of the oocyte. Now coming back to the chemical activation, like I said, the calcium levels or the calcium levels are primarily responsible for the block of the polyspermy that happens, and also the resumption of the cell cycle, so that the metaphase can be completed. Now there are several kinds of calcium ionophores that are produced, which helps in the flow of calcium ions into the cell and helps us in the activating the oocyte. The products that are available are the ionomycin or the calciumycin that are popularly available. If you look at the different studies that have been published, majority of this, there are quite good number of studies that are published using all these calcium ionophores for the use of oocyte activation. And it is believed at this point of time that artificial oocyte activation may be useful in selected patients where there is no or low fertilization potential, and may be considered in severe male factor disorders such as globozoospermia, severe tryptozoospermia, and in situations where there is non-obstructive azoospermia with previous fertilization failures. This is an overview of the different kinds of calcium ionophore protocols that have been used. Different people talk about using calcium ionophores in different ways. Some people talk about adding these calcium along with the sperm, injecting both these things together into the oocyte. They even talk about actually just after the ICSI process is done, the oocyte is put into a solution that contains calciumycin, and that is used for 30 minutes. And now that probably will help in the influx of calcium into the oocyte and help in stimulating it. So there are different kinds of scenarios or protocols used in different studies. But if you look at it, the data limit is quite limited as to what is the safety profile. So the long-term follow-up of these children born out of artificial oocyte activation remains mandatory, and hence it should not be considered to be a routine treatment and should be used in only frustrating situations where we have repeated oocyte failure. When we always talk about oocyte fertilization failure, we should always also think about in situations that when a patient comes to us with say a fertilization failure, not necessary that the same scenario can be repeated again. So repeated ICSI cycles do help in a lot of scenarios. What they even say is that a follow-up ICSI has shown fertilization in 85% of the cases which is having previous fertilization failure, because there are other factors, non-gamete factors, which can be contributing factor in that group of patients to have decreased fertilization. So when you're having repeated cycles, when you're using different protocols, probably the more number of eggs you're getting, the probable chance of us to get oocytes which are of good quality and possible chance of fertilization is higher. So sometimes when you do multiple IVF cycles or ICSI cycles, we have a possibility of fertilization or getting embryos which are fertilized. So to conclude, a total fertilization failure continues to be one of the most challenging aspects in ART treatment. So before we start on with any other procedure, we should also look into our own procedural capacity and upgrade our skill so that we at least assure that the fertilization failure is not because of us or our lab set conditions. Selecting a sperm, especially when you're doing ICSI, is very important, because it is very important that we select the right sperm for insemination. And as you all know, currently the most accepted, the most commonly used oocyte activation is by the chemical factors, but definitely make sure that you don't use it as a routine thing. At the same time, we should always look at the possibility of repeated ICSI cycles, which can be one of sometimes most of the time, which can help us in overcoming fertilization failure. So if it just like you have several possibilities in front of you, it is upon you to make sure that you do whatever you can in our own possibility to make sure that we actually end up getting a good fertilization, because ultimately we are answerable to a patient to make sure that we are able to give them good quality embryos and give them all possible ways to get a good pregnancy. Thank you so much for your patient hearing.
Thank you, sir. Thank you for the wonderful and informative session we had. And I would say it was a really well-balanced session where we looked into the factors from the oocyte as well as the sperm. And like rightly said, the most important thing is we should see whether there's any problem from our end, from the lab end. If we are up to the mark, then only we can go on to the gamete quality and other things. If we are not there up to the mark in the lab protocols and SOPs and KPIs, then we'll not know where the problem lies. And like rightly said by sir, we need to be up to the mark and we can do a lot of things. So there are a few questions coming up. So wait, sir, can we take the questions now?
Yeah, you can, please.
Sir, like you had said about the various techniques, if you have a patient of repeated failure, what is the sperm selection technique which you would advise a patient to undergo? A patient of say 3 or 4 ICSI failures.
See, if you're looking at ICSI fertilization failures or pregnancy failures, see, there are two different.
It's a pregnancy failure, I would say. Implantation failures.
See, what I think probably if you're looking at sperm selection, I would say any kind of sperm selection, there is no sperm selection technique that is being told to be very effective. But of all possibilities, I would say I would rather try and use, see, for example, I have an MC machine with me. So probably I will use, and I have felt that MC helps not in all cases, but in patients with repeated unexplained ICSI failures, repeated ICSI failures, not in all cases, I would again say, because I've seen that even if you look at the whole data, even if a lot of people talk about that MC is not proven to be effective, it is trying to emphasis on a general population. In general patients with ICSI failures, if you try and use, say, sperm morphology abnormalities, you look at all other abnormalities. When you generalize, see, any new technology probably is not suitable for all patients. There are certain technology that is suitable for certain group of patients. And I think from our own experience, probably what is working best in your lab, I would say always follow up at what you are doing and what you are seeing and utilize. I think, like I said, if you are taking into consideration that if there is some issue with sperm, or if you're looking at sperm as the sole factor for probably the ICSI failure, yes, microfluidics is a cheaper alternative. If you look at microfluidics, it's a quite cheaper alternative. And if you're looking at thinking that we are going to get sperms which are having less DNA fragmentation, because if DNA fragmentation is the reason for fertilization failure, yes, you can look at that. So that is the most commonest thing. But like I said, in our scenario, probably I use IMSI because I have the machine, but I wouldn't suggest that that is the only treatment available for repeated ICSI failures. But in our scenario, I'm getting good results, so I follow to use it. So always follow what you're actually doing in your own lab and what you are convinced with your own results.
Rightly said, like it so applies only to a subset of population.
Correct.
Only to a subset of population. We have another question coming up where they ask, say you have got a total ICSI fertilization failure and you have gone in for artificial oocyte activation with a calcium ionophore. And if it fails, then what do you do next?
There's nothing much we can do about it, because probably when you're looking at multiple oocyte activation failure, see, if you look at it, I think if you look at just like your empty follicular syndrome, no? I always feel there is this false oocyte activation, like total fertilization failure and true fertilization failure. Now, true fertilization failure, which is actually a major issue with the oocyte, there are limitations. See, even all these techniques that we are using, nothing is fully foolproof. We should be very categorically understanding that we are not going to come out with any kind of treatment that is going to give us 100% outcome. So there's definitely a fair chance of you to still get fertilization failure, because ultimately, whatever is said and done, these are techniques where they've said that your possibility of fertilization is higher. They never said that there is a 100% fertilization rate in any of these scenarios. So see, and when we are talking about fertilization failure, one very important thing that you should always keep in mind is we're getting two oocytes, and that both becoming not fertilized is not necessarily a total fertilization failure. So see, all those things needs to be kept in mind deciding on to what to do treatment. Like I said, do whatever we can in whatever possible way that we can, but beyond a particular point, I think gametes are gametes. There's nothing much that we can do.
One more question, sir. Whether there are any downstream effects of teaser sperm, like you had highlighted about artificial oocyte activation. So any downstream effects in the next generation or anything specific?
As of now, I don't think there has been too much of a study that has done a long-term study. Even they don't recommend it, or probably they still say that it's only an experimental purpose, but it is commercially available. The oocyte activation factor is commercially available and we are using it. But I think just use it for extreme scenarios where we are not left with any option. And one important aspect which I always felt is that I've actually done this mechanical oocyte activation, and it worked fairly good. It worked fairly well. So even though people talk about whether it can, we talk about doing ICSI so carefully that even the egg should not know that we have injected and left the sperm inside and come out. But in certain situations where we have actually done multiple aspiration, especially in globospermia, I think it has worked. But like I said, the number of cases are too less. So I would not know whether it has worked because of the oocyte activation done mechanically by me, or just that because globospermia does not necessarily mean that you have a 100% failure rate.
Okay, sir. I think it was quite wonderfully answered. That what works best in your lab, that is the thing to be followed with a scientific backing. And at the same time, we should caution the patient that it is not going to be 100% of foolproof, because otherwise the things are going to be different later downstream with us, I guess.
I think we can start with panel now.
Thank you, sir. Thank you, and thank you for answering the question.
Thank you.
Sanket, you can start for panel, I think. Unmute yourself.
Yes, I'm sharing the screen. One second. There's a lag in the presentation. 1 second, sir. Yeah, with two wonderful lectures, we'll be moving on to the panel discussion for today's session. So I would like to introduce Dr. Charulata Chatterjee, who is working as a senior consultant embryologist at Yashoda Fertility and Research Institute, Secunderabad. And she's a top-class expert with at least 2 decades of experience in the field of ERT. And she's a faculty speaker and participant at various workshops and CMEs and conferences. She has learned from the veterans like Hans Ingolf and Patrick Wynn and Catherine Dosky and Suresh Katera, Dr. Suresh Katera and others. And she has organized many workshops on CMEs, and she has publications like in internationally reputed journals. And to achievement, she has presented in many national and international conferences, including ESTE, ASRM, and IVS Spain. And on top of all, she's a mother of 2 children and lives at Hyderabad with her husband Debsis. And over to you, Charu ma'am.
Thank you, Sanket, for this kind introduction. And I would like to also introduce my this moderator, Dr. Rahul Sen. Where is he? He's there in the, yeah. So Rahul is embryologist working in Jodhpur, which is in the Rajasthan, and everyone knows in this our embryologist circle. So without much delay, Rahul, can you just do the introduction part of our panel discussion today?
He just messaged me. Rahul, are you there? Ma'am, actually, due to heavy rains, is facing some technical
Okay.
issues over there.
You have my presentation, or shall I share with my screen?
You can start sharing, ma'am. I'll stop my screen.
Yeah. So is it visible to all?
Yes, ma'am. It's visible.
On the onset, I would like to first thank Dr. David and Dr. Parshuram to make my work easier, because the today's topic, what we are going to discuss with our panel discussion, is sperm selection in the rare condition. I hope my all panelists are there and they are not stuck up with the rains. So we have with us Dr. Paresh Makwana, Dr. Harsha, Dr. Jailakshmi, and Dr. M.S. Srinivas. Is Srinivas has
Charu
joined?
ma'am, can you please put it for the slideshow?
Slideshow only. It's not
Ma'am,
coming.
just click
No.
enable editing and then make it slideshow. Enable editing.
Okay, wait. Give me a minute.
Charu ma'am, your screen is visible. You can start sharing your PPT.
Ma'am, you can download the PPT and then share. Done.
Is it visible now?
Yes, ma'am. Ma'am, just click on the enable
Slideshow.
editing. Yes,
Yeah.
ma'am. Yeah, ma'am. Yeah, from the beginning.
Right?
Yes, yes,
Right.
yes. We can go
Sorry
ahead, ma'am.
for this delay, and let us without wait we'll start. And as we all know that the aim of our all IVF is not only to see the fertilization and the embryo, but it is a birth of a healthy baby. So that's our major goal for any embryologist or any clinician. But over the years we can see that there is a declining in the sperm morphology. And even in the WHO, you can see that it is now a 4% is considered to be a normal. So definitely when we have to select the sperm, one have to be very, very careful about selecting the sperm. So what we look into the sperm, the first we see the morphology, like what we say in the Hindi, that first is darshan, then we check the DNA integrity, the mitochondrial function, and the chromosomal with that also, like what Dr. David has said, that we see the PLC zeta centrosome, there are lots of RNA species and the histones. But when you check the spermatogenesis, it can has a number of steps like mitosis, meiosis, and the maturation. So it can go anywhere wrong. So selection is based on many things. And if the sperm selection is not done or a sperm is abnormal, it can affect the embryo development at any stage, not only in the embryo development from zygote to blastocyst, but it can also affect the implantation rate and pregnancy rate. It can also land up with DNA fragmentation is high. It can land up into the miscarriage also. So these 6 steps of fertilization, which already Dr. David has explained, that there is a PLC zeta and calcium oscillation. Now, before we start, I just want to start with the basic, before I start into the cases, that sometimes as a senior embryologist, we take a lots of advances and we read about the advances and we try to implement that techniques into our routine IVF practice, but we sometimes, forget about the basic things. So the sperm selection, it's not only when we are checking the sperm into the ICSI dish, but it starts from the collection, that how the man has collected the semen, how does we have done the analysis, whether any advanced sperm function tests were necessary for that man or not, which sperm preparation is advisable for such kind of patient if analysis is says that it is a normospermic or oligospermic and all that. So that is must. So the sperm selection is basically 2 techniques at present. What we are using is density gradient and swim up. Now just I'm starting with my cases. So I'll start with Harsha. Harsha, are you there?
Yes, I'm here.
Yeah. So there's a first case. What I'm asking you, Harsha, is a 37-old man coming to our clinic with the non-obstructive azoospermia. The wife parameters, because we are discussing about sperm parameters, wife, we are keeping it as constant. And so it is a non-obstructive azoospermia. So my first question is that because here there is no question that it is azoospermic, so we have to do the surgical sperm collection. So surgical sperm collection, either it is a TISA, TZ or micro TISA. So what do you prefer, Harsha, that we are doing on the day of OPU or diagnostic surgical sperm collection? We just retrieve the sperm, freeze it, and then we use it. So that's the first question.
So, as this is non-obstructive azoospermia, sir, when we having a less chances of getting sperm in TC also. So, I think microdisa is the best option for this patient. And for timing of this, I will prefer the day before microdisa because you may get incubation time for sperms, because sometimes non-motile sperm can be have motility after around 48 hours also. So you can have a TISA prior OPU. The second advantage is there if you cannot able to get sperm in non-obstructive azoospermia, the patient may have a time for thinking about sperm donation also. So ideal is day before OPU or prior OPU procedure.
Right, very true. Now, for this particular couple, when they have done the surgical sperm collection, there was a non-motile sperm. So, is Jailakshmi there?
Yes, ma'am, I'm here.
So, Jailakshmi, if there is a non-motile sperm found in the TISA or any other surgical sperm collection method, so how we are going to proceed?
Non-motile sperm need not be a non-viable sperm. So it is very much necessary to select a viable sperm. There are.
I think, Jailakshmi, you are not audible.
Am I audible, ma'am?
Right, now.
Yeah. I was saying that non-motile sperm need not be the non-viable sperm. So the major goal should be to select a viable sperm. Yes, with a non-motile sperm, it is little difficult to do a real-time selection of the viable sperm. But there are many techniques available. The use of pentox, you can use incubate the sample with the pentox. You will get twitching or motile sperm after 10 minutes of incubation, or you can use a laser. As Dr. Parashuram said, just shoot the tail tip and it will curl, and that can also be used. You can use HOS also, where you see the swelling, and then that indicates the viability. And there is something called a mechanical touch also, where you touch the sperm tail and it comes back to the normal position. It indicates viability, but this is not 100%. I mean, you probably need a quite skill to do this, but then other three are quite effective methods to find a viable sperm.
Right. Harsha, I would like to ask you the third question, that do you find in your practice the difference between fertilization or embryo development rate between fresh and frozen TISA sperm or TZ sperm?
No, not at all. Even for microdisa, almost we are doing for non-obstructive spermatozoa, we are freezing of testicular tissues. So I think there is no any difference between fresh and frozen tissue sperms. There are so many papers and reviews available in last year, I think in 2019, Kenny et al. They compared fresh and frozen tissue sperms with 156 patients, and they got no any evidence for difference in fresh and frozen tissue sperms. You can use fresh or frozen, whatever.
So on the spot, both the panelists, with this scientific backup, I just close that when we are doing the TISA processing, sometimes we do use enzymatic method to just digest the tissues. Sometimes we use erythrocyte lysine buffer. You can prepare into the lab also, so that RBCs can be taken care. And there are two approaches. One is either we do TISA on the OPU day, and either we just do TISA, TZ or micro TZ before the OPU and freeze it. But I am also of that opinion that we should do in the advance, so that we shall have the time and for the counseling of the patient. And as there is no difference between fresh and frozen, so we'll have some time in hand to counsel the patient if sperms are abnormal, or there is no difference. If sperms are there, we can always thaw and use it for that. So this is the scientific backup, which says there is a like we have to do TISA before the actual procedure. The sperm preparation, either it can be a simple wash, density gradient, but when we are preparing for the TISA, I think I'm sure that we take care of our centrifugal force, so that it should not be damage our sperms. So this is a little bit, when you do the search, there will be, we have a little liberty to do our sperm preparation technique as per the sperm what we get into the TISA. Like suppose sometimes we get hardly 0 or 1 sperm per high power field, sometimes per slide. So depending on that, we can just little modified our sperm preparation technique. This is one of the paper. And as Dr. Parshuram also told, Dr. Jailakshmi also says there is how do we, immotile is not always, that is not a viable. So there are 4 techniques basically. We do HOS, we do mechanical method, and we do the sperm activation with laser, and sometimes we use as some motility enhancer like pentoxifylline or theophylline. So basically these 4 techniques is applied, and it has our own like techniques that in HOS where we are using fructose and sodium citrate, we see the sperm tailing. But when we are doing the HOS, we have to be at the time of ICSI. So we have to be pretty fast. So, there should not be any damage to the sperm. The motility enhancer, I told you, it is either theophylline or pentoxifylline. And there is a sperm tail flexibility test. So there is, say this paper says there is no absolutely difference between fresh and frozen sperm. So that's why I have included 3 papers. You are on the spot. Now we are going to case 2. Is Paresh there?
Yes, ma'am, I'm here.
Yeah. So Paresh, this is a case of obstructive azoospermia, and he's a 33 years old man. The first time he came for the like surgical sperm collection, but as he is staying abroad, he cannot come for again. So he has requested us to go and preserve his sperm samples, either collected from PISA or a TISA. So my first question goes to you is, when to throw TISA, on the OPU day or before OPU day? And in your experience, what is the ideal incubation time to have the maximum motility?
Yeah, actually, ma'am, as that Harsha said that we throw the frozen sample before a day. So we have enough around 24 hours incubation time, and the maximum incubation time in one of the paper they have maintained according to them you can do incubation for 48 hours, and after 48 hours also you get the motile spermatozoa. So in my experience, 24 experience is enough.
Good. And do you find any difference between fertilization rate when we are doing a TISA or you are doing a PISA?
It's a routine practice. Whatever we do, we first start from the PESA, and we got the from the PESA sample. Then we never go for the TESA. But actually, in some of the literature and recent literature, they told in TESA sample there is a higher chances of the fertilization rate and higher chances of good quality of the embryo. But but in our practice, we do PESA, and we don't find any difference between the PESA and TESA sample.
So, but whatever literature, Paresh, maybe you have read, that is a difference because it was of the high DNA fragmentation. When there is only between PISA and the TISA, but when there is no fragmentation is involved in case of the obstructive azoospermia, I will give you the like literature background and the scientific background. They didn't find any difference.
Once you found viable motile sperm, there is
Exactly.
no change.
So
No effect.
this is incubation time, as you said, that they have done 24 hours, 48 hours, and 1 hour, 2 hour, 4 hours, 6 hours, 8 hours, 12 hours, and 24 hours. There are 2 papers, but it seems that at 6 hours, the motility is maximum. So we can plan either 24 hours or 6 hours, or depending upon the TISA result. So that is again, it's that. And this paper particularly says that zygote activation seems to be independent of sperm origin. Either we are doing PISA or TISA. In case of obstructive azoospermia, where there is no DNA fragmentation is involved, the fertilization rate or embryo development is of no difference. Again, I'm coming to you, Harsha. The man is having a severe asthenozoospermia, and it's a complete absence of motile sperm. So the first question is, prefer viability test, which and why?
I think horse will be better for complete non-motile sperm, and which and horse is better because sometimes for training we cannot use that so much. Horse we can do at the time of ICSI also. So I think horse will be better. You can select motile sperm, viable sperms with horse.
Very true. And the sperm preparation and the sperm selection method?
It's a severe OAP, so I think the because of abnormal sperms, you should have to do INSI, intracytoplasmic morphological sperm selection. And sperm preparation, microfluidics also can be done. You may get some very few motile sperm and microfluidics. So I think INSI, ICSI, and oocyte activation should be.
So you do microfluidics when there is not motile sperm also?
Not motile. You said
I said absence of
oligoacid.
motile sperm.
So I thought there is lower motility, but yeah, for 100% non-motile sperm, you cannot go for ICSI. But in this situation, we can go for PISA. In PISA sample, you may get some sluggishly motile sperm. And in PISA also, you can use motility enhancer for these patients. I will prefer PISA with motility enhancer because I do not have good experience in ejaculated sperms motility enhancer. So PISA, motility enhancer, and oocyte activation will be better for this.
So if the man is not agreeing for TISA, then how do you proceed?
Then we'll go for horse and INSI.
Fine, good. So as we said that sperm selection is HOS laser, and this is it is a common irrespective of the sperm. So we can add that there is this paper is a beautiful paper which has explained that how to go ahead when there is a case of absolute asthenozoospermia. So the viability test, you correctly said that when you are using eosin nigrosin and HOS, the principle for both the tests is different. The eosin nigrosin stay in the sperm head and sperm head membrane, whereas HOS will tail protein. So you cannot combine. Plus eosin nigrosin you cannot use at the time of ICSI. So HOS is the preferable choice, correct. And motility enhancer we are going to use as this
Sperm selection.
theophylline. There is a very not routine use, but some paper says that they have used that ATP and magnesium sulfate, and some paper also had used when there is a oat or a stenoteratozoospermia, they have used a myoinositol. So that also not only improves the motility, but it the apoptotic marker which is MMP, it reduces the MMP. So probably it helps to reduce the sperm DNA fragmentation also. So that is about the case 3. Case 4, again I'm coming to you, Jai Lakshmi. It's a case of severe oligoasthenoteratozoospermia. The wife is in the normal range. The DFI is not high. It is also a normal. So the thing is, they have 2 failed ICSI cycles with a poor fertilization rate. So what will be your strategy for this cycle?
If it is the wife is normal, so that means there is no much of problem with the oocyte. Let us consider, so probably the lower fertilization rate is due to the poor sperm quality. So probably I would like to go for a IMSI because it has teratozoospermia, and probably for the oocyte activation also, if possible.
Right. So correct. When we can use IMSI, or we can go with the oocyte activation because it has a proven case of poor fertilization and not implantation. So IMSI is the first choice, and second is the oocyte activation. The participants who are with us from the beginning, they have heard Dr. Parshuram talking about oocyte activation, that it actually go with the calcium oscillation so that it can activate the oocyte and it helps into the fertilization. There are 3 ways. Can you tell me the 3 ways, Harsha, what the way which we are going to activate the oocytes?
First is electrical, with electric shock, so you can activate the oocyte. Mechanical, as Dr. Parshu said, during the ICSI, we can activate the oocyte. And third is chemical, by using for motility enhancer like theophylline or pentoxifylline, we can do a oocyte activation. Main thing I want to discuss with you in this particular case, as the person is severe oligoasthenoteratozoospermia, so sample pulling will be better idea for this patient, because sometimes what happens, very occasional sperm count and abnormal morphology, you need to have more than one frozen sample at the time of ICSI, so you will get
perfectly said. Perfectly said. So pooling is the first choice, and any IVF we use as a, even in the routine also we use one sample as a backup. So this is a mechanical, and I will tell you, when inomycin way back in 2001 and in 2002, when we were doing ICSIs, we didn't know about the calcium ionophore. It was not readily available, and I have tried this mechanical oocyte activation quite frequent, and I'm very happy with this, that you aspirate the cytoplasm twice and then again keep it in the center of the oocyte. These are the whatever methods. Inomycins is now available commercially also with the Gynemed. I just don't want to publicize, but it is available, and 5 micromolar to 10 micromolar you can use after ICSI for 10 to 30 minutes, and the oocyte is it helps into the oocyte activation, and ultimately it improves the fertilization. So, but the thing is this, as Dr. Parshuram said, that this inomycin cannot be used for everything because it has a limitations. It has not a proven RCTs has been done on the large scale. So it can be used on previous fertilization failure cycle in case of the globospermia, where there is a deficiency into PLC zeta, when there is a surgically retrieved sperm like non-obstructive, or when we are nowadays everyone is doing TISA because of the high sperm DFI, severe oat, teratospermia, and when we are using the frozen thawed oocytes for the donor cycle, that time I think we can implement this, we can use this calcium inomycin as a activation. Now the case 5 scenario, any one of you can answer. This man is having a history of diabetes and the secondary infertility. He could not ejaculate in spite of using all the techniques like given a non-spermicidal condom, vibrator or medicine, anything. And keeping in the view that it may be having some retrograde ejaculation, when the post ejaculatory urine has been checked, the sperm was found with a 4% progressive motility. So the first question goes to Jay Lakshmi, to you. What will you prefer? You will advise men to go for surgical sperm collection, or you will go with the preparation of sperm from the urine sample?
I would like to go for the surgical sperm collection if he agrees. Definitely yes, because having sperm in the urine could be detrimental. So definitely yes, for the surgical sperm if the patient is ready for it.
Now, I agree with you absolutely. This particular couple didn't agree for the SSC. So how to proceed?
In case if they don't, then the first thing is the checking of the sample should be done immediately, and add any bicarbonate buffer to the sample and process immediately, so you can get motile sperm. So that if you leave the sample with the urine or in the container, it might the motility might decrease. So the first thing is to process it fast, and then yeah, as I said, add some buffer to it so that the alkalinity is maintained.
Yeah, absolutely. You want to add something, Paresh?
Yeah, ma'am, this is because this is secondary infertility, so definitely patient will not opt for the surgical sperm retrieval. So better to collect the sample from the urine. First, give the alkalizer to the patient, then collect the antigrade sample, then collect after antigrade, take the urine collection and prepare the sample from the urine, and definitely he has a 4% progressive motility. Then you can select the spermatozoa with the help of the that IMSI or whatever the advanced technique is available.
Perfectly said. So we are, if his first choice is for the surgical sperm collection, and if it is not there, then to alkaline the urine with the sodium bicarbonate, giving into before night and before the sample collection, and we centrifuge and retrieve the sperm from the urine sample and can be used. And there are many case reports. Yes, Harsha, you want to say something?
Yeah, Ruben, I will add in this case, obviously you have to give sodium bicarbonate into 50 ml water, 5 grams sodium bicarbonate plus 250 ml water. So 1 glass of this solution before the day of collection. Same solution patient should be intact before 1 hour of collection, and then after 1 hour ask him to give urine sample and check pH. pH should be around 7.2 to 8, and osmolarity should be 260 to 350 molar osmol. So if it is more than that, then again ask him to intake this sodium bicarbonate, which will give better results.
Correct. So that's what it is written here. Same procedure. So that's the correct way to collect the semen sample from the urine and bring back the semen sample from the urine. Correct. So now case number 6 and 7. The fertility clinic, there are two brothers coming up with the, both are IT professional. Brother 1 is having a normal semen analysis, but high DNA fragmentation. Wife is a block tube, so absolutely we have to go with the IVF and ICSI. So, and the other brother having a severe OAT and the fragmented DNA. So I will.
Ma'am, Dr. Srinivas has joined, I guess.
Yeah.
Yes, ma'am, he's there. Srinivas sir, you are live now.
Good evening, Dr. Srinivas. How are you doing? Hello? Can you hear me?
Srinivas sir, you are live now. You can start.
Can I start, Sanket?
Yes, ma'am.
He is there. Actually, Srinivas is there.
But he
is not audible, sir.
Here.
Okay.
Ma'am,
You
please
please
proceed.
continue. Please continue.
Fine. So my question is like the
Yeah.
who is having a normal semen parameter and having a fragmented sperm DNA. So how would you proceed this for this couple?
For normal semen analysis, but high sperm DNA fragmentation, what is the age of the wife? Because the age of the wife is lower than DFI can be repaired by the oocyte repair mechanism. And because it's a normal semen analysis, we can do the density gradient or else we can go for the microfluidic. And after that, we can select the sperm with the help of the IMSI.
Correct. So you would go with the microfluidics and IMSI.
Yeah, and DG also helpful actually.
Pardon?
DG also helpful.
DG is also helpful. Are you not going to advise them max? For
any
what is the reason?
DG, max or microfluidic, any method, it will help to decrease the level of the DNA fragmentation.
Correct. Fine. So now this second couple who is having a severe OAT and fragmented DNA. So what is the advice for this man?
Severe OAT with fragmented sperm DNA. So in such case, if patient is agree, then we can go for the surgical sperm retrieval, because there are many articles that in a TESA sperm, there's a lower there are chances of getting a normal sperm better than that ejaculated sperm.
Fine. So now I would also want to add with you, Paresh, in the question 1, when we are advising for the couple to undergo max or a microfluidics or a density gradient, a short abstinence also probably help a lot to
definitely repeated
DNA fragmentation. So we ask couple to ejaculate a day before and morning of the oocyte pickup also.
Yeah, and on same day you can collect for the twice, you can collect the sample.
Exactly. So as we all know that DNA fragmentation can be because of the protamine failure, it can be because of the oxidative stress, or it can be because of the apoptosis. If maybe because of apoptosis, then max, where we are combining this annex B bits, then it helps to reduce the oxidative stress related DNA fragmentation. So, and we have to check that which DNA fragmentation test they have done to detect the fragmentation of the DNA. And according to, like, you know, there is a Jailakshmi, can you tell me there are how many methods to check the sperm DNA fragmentation? Can you, am I audible?
Yes, ma'am. Yes, ma'am. Can somebody take this question, ma'am?
Okay, Paresh, do you know that how many tests are available to check the sperm DNA fragmentation, and which is widely?
Flow cytometry one is there, which gives a better result actually.
Yeah.
In
Hello,
our
can
center,
I
we
come in,
do.
please?
Yes, Dr.
Yes, sir. Yes, sir. Please, sir.
Yes, DNA fragmentations are evaluated using a several method. One which is very advanced is the tunnel, but everybody what we are doing in our IVF lab is actually sperm DNA decondensation test. That is SCSA. Okay, you can do with aniline blue and the tunnel assay. SCSA is one which is very commonly used in all IVF lab because the kit comes with ready to use. If you want to use, there is another one where you need to use a fluorescent microscope. You need to use a fish method. It is actually where wherever the fragmentation is there, this dye is going to be there labeled, and that you will see through the fluorescent microscope. That is not in practice, but what we always use in actually halo test. Halo test is done for this one where the dispersion of this chromatin material will be there for DNA fragmentation. This
So
is
it is
all.
very
These are
rightly
all.
said by Dr. Srinivas that either we do tunnel, there is another test called comet assay,
Yes. Comet
sperm,
assay.
and
Yeah,
all flow cytometry. So now
yeah.
my question is to you, Dr. Srinivas, that do you suggest a couple based on the level or the degree of the DNA fragmentation to undergo the sperm selection method? Like suppose the sperm DNA fragmentation is between 15 to 25. Do you have that cutoff value that this and this we are suggesting this sperm preparation or a sperm selection method? And if it is not in that level, you are suggesting a surgical sperm collection?
See, whatever the method we use, actually, there is a threshold value. Okay, the kit along with the kit, the threshold value comes. That is where we will have to identify. Like I mentioned, all these tests are a qualitative; they are not a quantitative. But tunnel assay is a quantitative. But
Right.
it is very expensive, which we cannot do it. But coming
Explain.
to your question, actually, if they are coming within this thing, fragmentation is there, how we can be able to do it. But we need to remember that whenever we use all these sample, this is to do the DNA fragmentation. Same sample is not able to available the day when you do the procedure. We don't know what extent the DNA fragmentation is there. But
Right.
like you said, no, it is better to have a fresh ejaculation where you will be able to avoid the fragmentation. So where here, the fragmentation, whenever you have all these things, if you know all these things, you cannot be able to do it. But whenever you perform the ICSI procedure, actually, there is a method by which you will be able to select a sperm which doesn't have a DNA fragmentation. That is the IMSI method. Whenever you look under higher magnification, you see, where is the vacuole exactly it is, if it is in the center, in the periphery, how big is the vacuole. So the vacuole presence may be the indication for the DNA fragmentation. This is how you can select it. But if you know the patient is DNA fragmentation is level more, if you post this patient for doing the IVF procedure, that the ICSI procedure, for embryologist it is challenging to select the spermatozoa. It is better to put a patient on a clinical where antioxidant is there and do whether the level is come down.
What
Then
is,
it can be
have you anybody used the Pixie for the high DNA fragmentation, and what is your experience if anybody has used?
see.
I have done one twice, but there was not much. I mean, nothing much higher fertilization wasn't achieved. Even the oocyte quality was bad. So I don't know whether it was because of the sperm or it was the oocyte quality also. But not much difference in the fertilization.
And when there is a
Charu,
severe,
Charu, can I come in?
yeah,
Okay.
sure.
This pixie is actually, these spermatozoas are going to bind to the protein, okay, hyaluron protein. It is which is there in the acrosome area. Okay. I don't think it is interrelated to wherever the the spermatozoa bind to this pixie dish, which doesn't have a DNA fragmentation. which because no, even receptors are very less, these sperms are bound to bind to the epixy dish. I don't think this DNA fragmentation is related to the sperm which is bind to the dish.
Very rightly said, and it is not going to, very useful where there is a high DNA fragmentation. IMSI, of course, when Dr. Srinivas has told that vacuoles is indications for DNA fragmentation. So IMSI in selected cases, it will be useful for the high sperm DNA fragmentation. And IMSI is also useful for many, previously cycles and indicated case. Microfluidics, of course, when you feel that there is a normal sperm parameter, because the final volume what we are going with this principle and the technique is very less. So in my experience, CV is not going to give you a best result from microfluidics, but microfluidics, I do not know anybody has done the experiment that before the collection and after the microfluidics, if someone has checked the sperm DNA fragmentation, we can going to say that yes, it is going to reduce the sperm DNA fragmentation. The max is also useful with oligoasthenospermia and normospermia also. And max gives, I am happy with the max result. And in fact, I have done few cases where we have sent the after max the resultant semen prepared semen for the DNA fragmentation, and when we have compared, we have found that DNA fragmentation is less into the max prepared. And there are a number of articles which suggest that max is helpful for the DNA fragmentation. Pixie, as Dr. Srinivas told, it is not going to help you, and Cochrane analysis also in the 2015 says the same thing. Now, the case what I'm going to have with me in my kitty is the man with the 3 semen parameter, 3 times semen analysis is done, and it has been labeled as cryptozoospermia. So what will be the preferred sperm selection method? Harsa, are you there?
Yes, I'm here.
So in case of cryptozoospermia, are you going to use a frozen sperm, fresh sperm, TISA, or any other mixed strategy?
Again, here also I advise for pulling of samples, because in cryptozoospermia, the number of sperm will be very less. So pulling of samples, if patient agreed for testicular retrieval, it will be better, because for cryptozoospermia, the quality of sperm is not good. So ideal, we should go for SSC, surgical sperm retrieval, SSR, and pulling of samples. Besides activations, I advise for this patient.
Correct. So any other thing you want to comment, Jayalakshmi Fawadu?
As Dr. Harsha said, yes, pooling of the sample. And then we see the sperm, and then in case we don't get enough sperms in both the samples, then obviously we can advise for the surgical sperm retrieval. So I would like, again, we'll go with Dr. Harsha.
Paresh, you want to add anything?
Can I come in?
Yes, sure.
See, cryptozoospermia, when we report it, actually, whenever you don't see through the microscope, okay, then you centrifuge it, and in that, if you see, then you report it as a cryptozoospermia. That means these are all not motile spermatozoa, what I feel. If you want to check whether these the spermatozoas are motile, HOS test has to be done on the day of whenever you find out this one. When you figure it out, this is actually the very poor sample. I think surgical method is the way by which you will be able to, get the spermatozoa for the procedure. Because pulling up the spermatozoa, then you'll have to check the viability of the thing only. Why you need to go for this? Okay, with cryptozoospermia, I don't think the motility is seen.
If a man, I would also ask one more question, Srinivas sir, that if man is having a cryptozoospermia with high DNA fragmentation, what is the best method for the surgical sperm collection, TISA or a PISA?
No, this is TISA only, because again, if you want to take a piece of sample, it is exposed to the stress. Okay, you might get the spermatozoa which has got a DNA fragmentation more. It is better to get directly from the TISA. Even sometimes it is known that
good.
if
So
you
from the sperm production site, which is directly from the factory, the goods is always better. Good.
yeah, it is always better because no, if you do clinically PISA, no, the
Correct.
fibrotic, all these things can happen.
Right.
It can
Very
lead to
true.
other complications.
So there are scientific evidence suggests that you can go with the surgical pump collection, or you can also pull the sample and freeze, and the pool sample you can use for ICSI. So now this case, I think Harsha would love to answer this. The man with the testicular failure at the maturation arrest, not for the sperm donation, how to proceed?
So this is primary testicular failure. So I think, Sharman, you should have to have 2-3 semen collection, and sometimes you will get very rare sperm in ejaculate also after centrifugation. So it is better to search for a sperm in 2-3 samples. TC or micro TC. Micro TC I will advise for this sample if you will not get sample in ejaculate. Artificial.
Okay, hypothetically, we are assuming that in the sample after centrifugation in the this TZ also they did get the mature sperm. What is next?
Roshi?
Pardon?
Round
Charu, can I take leave with your permission?
Sir, answer this and leave.
Okay, thank you.
Thank you.
So I will advise Roshi or Rosalie round spermative injections. We maybe get fertilization after this.
Very true. Jayalakshmi, you want to add something?
Yes, ma'am. I mean, there are some less than 20 pregnancies reported out of the Rosny. So probably you can take chance and then inject the round spermatids. Yes.
Correct.
Paresh? Ma'am, here the patient counseling is very much important for the outcome actually.
Right. So this is like as we are discussing the rare. So this will be the rarest of rare case. It is not the rare like Arusi Talwar case. So it is rarest of rare case where you find a very round spermatid, and you can inject that round spermatid Roshi or Roshni. And with the Roshi, even in our India also pregnancy noted. I think Harsha with your center also, I think pregnancy noted, and the doctor
I tried
given one article. Yes.
I tried once. I got good fertilization. But not
good.
pregnancy.
But there is one paper when I was preparing this thing, I found that there is one Indian like 2 cases has been given into the healthy childbirth, and so far some 17 pregnancy has been have the live birth with the Roshi, but still it is considered as a research or whatever it is. So that's a case of Roshi. Now coming to the case scenario of 10 and 11, though such kind of cases will not occur in our day-to-day, but as I want to include with all the parameters, we think of some rare cases. So again there were 2 couples. Husband was staying in the outstation. In spite of reminding, they didn't send us the semen analysis report or seminal culture sensitivity test. They land up on the day of oocyte pickup only. The patient 1 is having a hematospermia, and the patient 2 is having a leukocytospermia. So first I would like to someone answer that how do you tell that this man is a leukocytospermia, and what are the tests to confirm for the leukocytospermia? Paresh? I can't hear you.
Unmute.
Harsha, you can take, or Jayalakshmi, you can answer.
Dr. Paresh, you can unmute yourself.
Maybe someone else take the
Yeah,
question.
Harsha, you can answer this. Okay, how do
So
you
for
identify what
hematospermia,
is
you
the
can
lab test to, pardon?
for hematospermia, you can see under high power microscope RBCs for both the leukocytes. Also, you can see color of semen sample. By visually, you can see reddish color or yellowish color in leukocytospermia. The procedure, ideal procedure should be microfluidic now as it is available. Before microfluidic, we were using density gradient, but it increases the ROS and everything. So microfluidic pump preparation will be better, I think so, in this case.
Which hematospermia or leukocytospermia?
Both the case, ma'am. Both the case, if motility is good, then you should use microfluidic.
Okay, so now as per, there is one specific test to identify the leukocytospermia. It is an ANDS test. And of course, we check the RBCs, but in case of RBCs, what we advise is surgical sperm collection. If at all he is not agreeing, we can use the RBC lysing buffer. As you said that for leukocytospermia, we use double density gradient because glass full is not more in the practice, and we can combine it with microfluidics if the semen parameters are in the normal range. So this is a one.
Already
for
other
the,
cells are there, ma'am. Already other cells are there, like WBC and RBCs are there. So it increases the ROS formation and is detrimental to pumps. So I will prefer microfluidic than centrifugation of sample.
Probably the number of cells present in the semen also, if there are not high numbers present WBC or RBC, you can go for a density gradient, not with the hematospermia, but of course, yes, with the leukocytospermia. So the number, it depends on the number also, how many, what is the contamination percentage. So if it is high, then as Dr. Harsha said, yes, go for microfluidics. If it is less, then probably the double density gradient will work.
So whatever, like in this all 11 cases, what I have included is we have done in our practice for some or other cases. Now, what are the advances we are looking into the sperm selection and sperm preparation method, that maybe in the coming years we have to ask the gamete only कि भाई तुझे क्या चाहिए, तेरे में क्या कमी है, what I want to push so that you can have the healthy baby. So as I said that PLC zeta, what Dr. David has told in his lecture, that PLC zeta injection, centrosome, RNA and the histone code. So DNA we are taking care with MAX and microfluidics and IMSI and all other tests. We are checking it with the tunnel, comet and all other assays. PLC zeta, like maybe in the coming future, we can, if we have some test to identify that sperm is having or previous fertilization failure, if we detect the PLC zeta and if the sperm is deficient into the PLC zeta, probably we can inject the sperm with the PLC zeta. Same way, there is experiment is done in 2009 by they have injected this centrosome with the ICSI and they got the good results. So probably if there is a centrosome abnormality into the sperm, we can probably in the future we can use that. The RNA is also in the animal model, when they taken out the RNA and inject the animal oocyte into the mouse and all that, they have not only see the different or deficient oocyte activation and fertilization, reduced fertilization, but in the progeny also the epigenetic changes also they have seen. So probably when we do a microarray or if we have the Raman spectrophotometry where we can have the 3D picture of the sperm, all this deficiency we can find it out from the sperm and we can pick up the healthy viable sperm and to have the healthy baby. So the microarray, Raman microspectrometry, and as in the earlier lectures also we said, and Paresh also mentioned that there is a repair mechanism by oocyte itself. So we should not forget the female counterpart. If the female counterpart as usual can cover up that deficiency, probably we can overcome this sperm related problems. So sperm preparation is a gold standard in sperm selection, because on the basis of that we can detect the good sperm. and ultimately we have to use the either it is a motile, non-motile. We want a healthy, viable sperm to inject the oocyte. Now the stage or whatever this discussion is open for the participants to ask any questions. The panel is over here. I think I have finished on time.
Yeah, you finished on time.
Right.
So thank you so much on behalf of ihera and our academic partner MCure. I want to thank all of you, and special thanks to Dr. David McCullough who joined us today for excellent lecture, and of course Dr. Parshu and our moderator Dr. Charulata and Dr. Rahul. Rahul couldn't join us because of bad weather, and our panelists Jayalakshmi, Harsha, and Dr. Srinivas and Dr. Presh Makwana. So we have two upcoming events: embryo quality and implantation potential on 29th of August, and revising fertilization strategy in ART part 2 on 8th September. Please join us, and we're happy to announce something big is coming. Detail will be announced in our upcoming webinar from Team Hera. So please join us on 29th again. And over to Dr. Amit. And sorry, special thanks to our Dr. Jafar Ali, who also joined us today. He is on our advisory board. And thanks to Dr. Amit, and Mr. I think Mr. Rajiv is not there.
Sir, Rajiv sir will not be today here. So,
okay. And
so
Deepak also.
Yeah.
Dr. Jafar is here.
Yeah. So thank you, sir. Thank you very much for giving us an opportunity. We are truly honored and humbled to have such a great webinar, and being an academic partner really counts for us. We really value this association, and we at MCure will be always dedicated to such academic activity, and do let us know. Thank you very much to Dr. Ved Prakash sir, Dr. David sir for joining us for this webinar. Dr. Charulata ma'am for fantastic moderation, Dr. Sanket sir, Dr. Akash sir, Dr. Harsha ma'am, and Dr. Jayalakshmi ma'am, Dr. Paresh sir as well. We also
I think I should say special thanks to that little Temur.
He's there throughout our webinar.
Good. So thank you all. Thank you, Mr. Dr. Ved, and thank you MCure, and thank you ihera, and thanks to keep our gray cells activate. Thank you.
Thank you so much.
Thank you.
Thank you, David sir, and thank you, Dr. Jafar Ali. Thank you so much.
Thank you.
Thank you.
Bye bye. So with your permission, I'll close the session, sir. Thank you very much.